Yeah, and doing it over 2 years.
Should we give it another 2 minutes?
You're good.
I'll be the one guys that get some great green.
Yeah, I just met her this morning. She's like 2 weeks. Yeah. So you
Oh, I've noticed this. So we had similar research interests. Yeah, she's
so they're all the residents of all the mental health safety exams. Yeah, mental health safety exams, residents. I think it's just
it's just like something was like, oh, yeah, Andrew was saying like,
Okay, introduce it. Hello everybody, welcome to What's New in Addiction Medicine. It's my great pleasure today to introduce Dr. Anne Sutherland. She is a fully trained emergency physician working part-time, just started working at Vancouver General Hospital Emergency Department, but doing her fellowship at the same time through St. Paul's. She did her undergrad in Alberta, and she did a MSc in pharmacology and toxicology at Queen's, and then most of her training after that was in Manitoba. So she knows the country well, and now she's happily settling into Vancouver. She's speaking to us today on managing substance use disorder in the emergency department setting, I think with a real focus on opiate use disorder, because that's the crisis that continues and won't go away. So looking forward to hearing an update on what we're doing in both hospitals in Vancouver around these issues. Thank you.
okay. Thank you, Dr. Mead, for the very kind introduction. Before beginning, I just want to take a moment to respectfully acknowledge the land on which we work is the unceded traditional territory of the Coast Salish peoples, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. By the end of this talk, I'd hope that the individuals here today will come away with up-to-date knowledge underlying the rationale behind screening patients for opioid use disorder in the emergency department, even those who don't present with opioid overdose. I'll also be discussing the evidence behind utilizing harm reduction strategies from the emergency department. And then I'll be talking about starting opioid agonist therapies in the emergency department, particularly around Suboxone and the Suboxone to go program that has been rolled out in St. Paul's, with a plan for a rollout at Vancouver General Hospital in the coming months. So as we know, British Columbia is in the midst of an opioid crisis. From this chart, which many of you have seen, we'll see the numbers of drug overdoses in the province from BC, and you see the greatest increase from 2016 onwards, when the opioid crisis was declared in April of 2016. There were 993 deaths in 2016, 1,458 in 2017, and greater than 1,500 in 2018. So this includes confirmed and suspected illicit overdose deaths, and this includes street drugs, medications not prescribed to the decedent, and combinations of those with prescribed medications. And notably, an update from January 2019, there were 90 suspected overdose deaths in January, down from 130 in January 2018. So this is a 31% decrease in the year from January 2018 to 2019, but this still equates to 2.9 deaths per day. So looking at this chart, you're looking at the dark blue line, which includes all illicit overdose deaths. So this is the line here at the top. And the dashed line is the drugs where fentanyl was excluded. So fentanyl has been implicated in 82% of overdose deaths in 2017 and 87% in 2018. So that's a 7% increase between 2017 and 2018. So inferring from this data, it's suggested that fentanyl appears to account for the increase in drug overdose deaths since 2012, as the number of deaths, excluding those with fentanyl detected in the bloodstream, is relatively stable since 2011, with approximately 285 deaths per year. From the coroner's report in 2019, the highest number of illicit drug overdoses come from the locations of Vancouver, so the Greater Vancouver area, Surrey, and Victoria, with the highest rate of illicit drug overdose deaths in the Vancouver Coastal Health Region of 37 per 100,000 people. And where are these deaths occurring? So 62% of these drug overdose deaths occur in private residences, 26% in other locations. So this includes social supportive housing, SROs, or single room occupancy hotels, shelters, outside, 11% of deaths. And then notably, it still holds true that there are no deaths at any supervised consumption or overdose prevention sites. So from this data, it may be inferred that a big risk factor for death from overdose is using alone in a place where no one can find you, or in a place where there's no access to naloxone. So naloxone is an opioid antagonist, can be used by intranasal or intravenous administration to reverse an opioid overdose. Prior to EMS being called or upon EMS arrival, this is a life-saving intervention. So since 2012, take-home naloxone, the distribution program through the BC CDC, has distributed more than 75,000 kits across the province, with nearly 20,000 reported as being used to reverse an overdose. So this data comes from the BC CDC with the Overdose Emergency Response Center. This is a quarterly report here, looking at the number of kits that have been reported as used or returned. You can see a spike that comes up in 2016 there. And so that spike in the number of overdoses reversed corresponds with the declaration of the opioid crisis. So this study that was completed in Massachusetts in 2013 to 2015 looked at over 12,000 EMS naloxone administrations. So of these 12,000 EMS naloxone administrations, 10% of these patients died within 1 year. And so that's approximately 1,200 people. And 600 of those died within 1 month of that EMS naloxone administration. So while naloxone does save lives, it does not prevent future use, and each use of any illicit opioids puts a person at risk of death. So this is data that comes from BC, and it's data on fatal overdoses from 2015 to 2016. Now, 12 months prior to overdose death, over half have had at least one emerge visit, and this doesn't just include overdoses. 1/4 of these people had at least one prior hospital admission, and 3/4 of these people had at least one community-based emergency or community-based physician visit. So all of these access points are critical for people who struggle with substance use. And from 2016 to 2017 in BC, this data comes from coroner investigations, which includes obtaining information from family, from physicians, medical records, PharmNet records, other relevant sources. And this report looked at 872 completed illicit overdose investigations. And so from 2016 to 2017, 79% of those people had contact with any health services less than 12 months prior to death. 56% of these people were presenting to physicians with pain-related issues, and 52% had either a clinical diagnosis or anecdotal evidence of a mental health disorder. And in the Vancouver coastal region, from 2016 to 2017, with 400 deaths, over half, or half, had 2 or more visits to the emergency department in the 12 months leading up to their death. So the emergency department has evolved over the last 50 to 75 years to be the universal point of access, diagnosis, treatment, and linkage to definitive care for many people who present for many different reasons, but particularly for opioid use disorder. With regards to time-sensitive treatment and stabilization, people who work in the emergency department are responsible for reversal of overdoses and treatment of withdrawal from opioids. As an acute diagnostic center, it's our responsibility to serve patients coming in with altered LOC to assess their cause of their altered level of consciousness, and to identify opioid or patients who suffer from opioid use disorder. And from a healthcare access and treatment linkage perspective, it's our responsibility to serve as a place where referral to opioid use disorder treatment facilities or medications may be provided, or to provide harm reduction interventions for these patients. Now, looking more specifically at St. Paul's Hospital, St. Paul's Hospital has approximately 82,000 visits per year as per 2017 data that has been gathered by Kessler. Dr. Kessler here, who works as the emergency department physician, who does quite a bit of research on opioid use and opioid use overdoses, opioid use disorders within the emergency departments. Overdoses are just the tip of the iceberg. So with these patients who come to St. Paul's, the screening data has been gathered from patients who are 16 years or older, who had self-reported illicit opioid use within the past 6 months, or who were prescribed daily methadone or Suboxone, or who had daily opioids greater than 100 morphine equivalents or 100 milligrams of morphine equivalents in the last 6 months, and who had clinical presentation suggestive of opioid use, overdose, or withdrawals, who were coming in with an opioid prescription request, who were coming in with soft tissue infection thought to be related to opioid use, or who were referred to the team by either a nurse or physician based on clinical judgment. Now, this data was gathered from research assistants who covered shifts between 9 a.m. to 9 p.m. for 12 weeks, who reviewed chief complaints, triage notes, out-of-hospital notes, and pharmacy database records. So you can see that opioid overdoses are just the tip of the iceberg. Some are coming in with opioid withdrawal, 13% with skin soft tissue infections. Purple is other opioid related, which can include patients coming in with requests for detox or prescription opioids. And then 55% of patients, so over half of these patients, were coming in with non-opioid complaints. So either mental health complaints or medical complaints, including chest or abdominal pain, fever, shortness of breath, et cetera, et cetera. So you can see that quite a few of these patients may have been missed if they were not screened. So from the emergency department, the best practice should include screening for substance use in patients presenting to the emergency department, not just patients who present with overdoses. Now, if the patient is either pre-contemplative or contemplative, which means that the likelihood of them having cessation of their opioid use is very low, it's imperative to discuss harm reduction strategies. So this includes access to clean supplies, locations of overdose prevention sites, giving them either a take-home naloxone kit or ensuring that they have a take-home naloxone kit and know how to use it, and looking or sending them to a place where they can access either drug checking facilities or counseling them to provide themselves with test doses prior to full use of a full dose. So this is a list of the locations of drug checking locations within the Lower Mainland. Of note, drug checking is available at all overdose prevention sites. It's done either by fentanyl test strips or by spectrophotometer. Now, it's available for fentanyl test strips at all locations at all times.
Code ECPR, CCU, Providence Level 3.
I'll just let
Code
this.
ECPR, CCU, Providence Level 3. Code ECPR, CCU, Providence Level 3.
So the checking via fentanyl test strips can be completed at any overdose prevention site at any time. And then the spectrophotometer, which is available at these locations at certain times. So a fentanyl test strip, effectively what needs to occur is the person provides their substance to be checked. The substance is diluted with water, and the positive result is available within seconds. This detects fentanyl and fentanyl analogs like carfentanil. A spectrophotometer is a more specific way of drug checking and can provide knowledge based on the adulterants or other substances within the substance that the patient would like to use. So, of note, at Insight, there's data that suggests that patients who checked or people who checked their drugs and got a positive for fentanyl were 10 times more likely to reduce their dose of fentanyl. And for those who reduced their dose, they were 25% likely to, or 25% less likely to overdose than those who didn't check or reduce. There are other locations to check your drugs. At Broadway and Commercial, at the Robert and Lily Lee Family Community Health Center, or the Foundry at Vancouver Granville. Ultimately though, if the patient is presenting to the emergency department and they have a diagnosable opioid use disorder, it's imperative to talk to them about opioid agonist therapy or consider accessing help via an addiction specialist to counsel or start the patient on OAT. Because we know that Suboxone and methadone do save lives. So this is a meta-analysis completed by Sordo et al. In the British Medical Journal, done in 2017. It looked at the all-cause mortality in and out of opioid agonist therapy, for those who had been on methadone or off methadone, and those who had been on Suboxone or off Suboxone. And looking here, this is the overall pooled data for methadone. So in treatment, the all-cause mortality rate is reduced for methadone, right there. And in treatment, all-cause mortality on buprenorphine and naloxone is reduced as well. Importantly, Suboxone is the first-line treatment in BC. It's very safe. As of yet, per the coroner's report data from 2019, there are no deaths seen in BC to date with Suboxone within the patient's presentation in the coroner's report. And Suboxone does have a better safety profile, and it does stabilize addiction within 1 to 2 days with the standard dosing of Suboxone. So this study was completed by D'Onofrio et al. In 2017 at Yale. So this was completed within the northeastern state at a single center. This was a randomized control trial looking at the benefits of the initiation of buprenorphine in the emergency department. So patients were randomized who had presented with opioid use disorder to 3 treatment arms. The first was screening and simple referral. The second was brief intervention and referral. And the third arm included both brief intervention and referral, but also included a Suboxone induction, either within the emergency department or they were provided with take-home Suboxone. So patients that were excluded from this group were those currently in addiction treatment, those requiring opioids for pain management, those who required admission to the hospital, or who had a current active medical or psychiatric issue. So they randomized 329 patients to 3 treatment arms. So referral to treatment is effectively a group where they were given a list of local addiction resources. This included both residential or inpatient treatment centers or outpatient treatment resources, or a list of physicians who could provide them with opioid agonist therapy. They left it up to the patients to contact the service or the clinician of their choice, and no motivational statements were provided. The brief intervention group with referral to treatment was similar to the first group, but there was a 15-minute interview that was based on a negotiation interview. This is essentially a form of motivational interviewing. In addition to this, there was a facilitation of post-discharge facility or resource options for the patients who came in. The research associate discussed a variety of treatment options. They went through all the list, but then they directly linked the patient with the referral. So that's a step up from the just referral group. The last arm, which was in addition to the brief intervention, I also added a Suboxone start in the emergency department if the patient presented in moderate to severe withdrawal. But they provided Suboxone as a take-home dosing if the patient was not in moderate to severe withdrawal. So at a 30-day post-emergency department visit, 37% of the patients who were in the referral group were still retained within addiction treatment. In the brief intervention group, 45% were still retained in treatment. And in the Suboxone group, whether or not it was take-home Suboxone or Suboxone start in the emergency department, 78% of these patients were still retained in treatment at a 30-day time point. And it's important to know that about 50% of the patients in the Suboxone group had take-home doses and about 50% had in-emerge starts. All right. So Suboxone is currently offered within many of the hospitals, if not all of the hospitals within the Lower Mainland. There are pre-printed order sets for both standard and microdosing within many of these hospitals. So standard dosing is such that a patient has to be in moderate to severe withdrawal prior to starting on Suboxone. So a COWS score greater than 12 prior to receiving their first dose of Suboxone. This is in addition to a time course of last opioid use. So you always have to clarify when their last opioid use was prior to starting Suboxone. The patient must not take any other opioids during a standard Suboxone start. The therapeutic dose for a standard start is reached within 1 to 2 days, with higher doses administered at the time of the start. Microdosing is done over a course of approximately 7 days. Smaller doses are administered, and the patient can continue to take other opioids either within the hospital or illicit opioids outside of hospital until a dose is reached that is therapeutic. This does not require a COWS score. And most importantly, Suboxone to go is now being offered at the St. Paul's Emergency Department as of December 2018. So the to-go packs include a 3-day supply of Suboxone in a standard dosing induction. This can be dispensed by addictions nurses, addictions physicians, or emergency department physicians. The follow-up for these patients, if they're not currently hooked up or connected with a clinic, these patients can be followed up at the St. Paul's Rapid Access Addiction Clinic, which is on the 2nd floor of the Burrard Building, or the VCH Connections Clinic. The assessment of these patients must include whether or not the patient is currently in opioid withdrawal, or if they're dope sick, is a word that you might hear the patients use themselves. They must have a diagnosable opioid use disorder. Be careful with these patients if there's infrequent use or if there's an accidental opioid overdose during a primary other drug use issue or disorder. If there is concurrent opioid agonist therapy on their Pharmanet, or if they're pregnant, the addiction service must be consulted here. And if they're in acute withdrawal, they may be a candidate for Suboxone start within the emergency department. The education for the patient must include discussion about precipitated withdrawal and how to avoid it or how to manage it, and how to administer the medication. As part of these patients' presentations to St. Paul's, the overdose outreach team is also consulted. So the inclusion criteria for this group of patients, as I mentioned, the patient must have an opioid use disorder, and they must be at least contemplative for a Suboxone start. This inclusion criteria is meant to be low barrier to access many patients. And as I mentioned, if they're in acute withdrawal, I consider an emergency department start of Suboxone as opposed to a Suboxone to-go pack to be dispensed. Exclusion criteria for this group: if they've had a long-acting opioid within the last 72 hours, methadone, Cadian, or potentially Suboxone, medical, psychiatric, or substance use disorder that makes take-home dosing unsafe, if they have diagnosed acute hepatitis or decompensated cirrhosis previously or on this emergency department visit, or if they are pregnant. And notably, the emergency department prescriber, the addiction medicine consult team, or the addictions assessment nurse can initiate these orders. Other considerations for these patients who come into the emergency department is a social work consult for social supports, access for residential or inpatient treatment, or further support regarding housing. Prescription for adjunctive medications may be provided for these patients as well, so providing supportive care should they have any further withdrawal or precipitated withdrawal. Medications that can be considered: Gravol or ondansetron for nausea, ibuprofen for cramping, clonidine for autonomic hyperactivity, loperamide for diarrhea, quetiapine for agitation. Of note, these patients may come back to the emergency department after a Suboxone start that had been initiated in the emergency department. Important considerations here would be to confirm any further community prescription of any opioid agonist therapy, or had they received or taken any other opioids since their last dose of Suboxone. They may be provided with a continuation script within the emergency department, or with an increased dose of Suboxone if they have ongoing cravings or worsening cravings, or if they're presenting in any opioid withdrawal. So I wanted to take a minute here to discuss the role of the addictions assessment nurse within the emergency department here at St. Paul's. This is a registered nurse that is specializing in addictions. They provide support for patients with regards to harm reduction, access to treatment, and either engagement or reconnection to care. They also provide a role as a liaison with other care providers or with the overdose outreach team to provide continuity of care. So here at St. Paul's, the addictions nurse sees patients that are unlikely to be admitted, but who presents with substance-related issues. And the addictions assessment nurse, or AAN, is responsible for the assessment of patients with addictions during the day and can dispense the take-home Suboxone. There should be a low barrier to consult the AAN. So emergency physicians, psychiatrists, consult services, nurses, and social work can all access the AAN services. And their location within the emergency department allows for quicker, focused assessments in the hope to prevent any patients who may leave against medical advice and to hopefully prevent readmission of these patients to the hospital. So this is an example of the teaching that's provided to patients who are provided with take-home Suboxone. They're provided with the following instructions. So the pill is taken sublingually and it must dissolve completely. So it can take up to 10 minutes. The patient should not swallow their saliva or the pill and refrain from talking or drinking fluids while the pill is dissolving. There's also an instruction to avoid smoking or drinking coffee approximately 1 hour before taking the pill, because being hydrated can help dissolution of the tablet. Now, it's important to also provide the following information to the patient. The worse they feel, so a minimum of 3 withdrawal symptoms, the better they will feel after they take it, or hopefully the better they will feel after they take it. So the common instructions as listed up here, they give them a list of the withdrawal symptoms there. And they give them a very clear instruction on how to take it. So take 1 tablet when you feel at least 3 withdrawal symptoms, wait an hour. If you feel sick or still feel sick, take 1 more tablet, wait an hour, and then try again in 1 hour. They're provided with 36 milligrams or 3 days supply of 12 milligrams per day in 2 milligram pills. So they're taking 2 milligram tabs, 1 per hour until they feel better, or they've taken all 6 tabs in 1 day. And day 2, day 3, take all 6 tabs. And then referring them along to the Rapid Access Addiction Clinic. This is a clinic which is located on the 2nd floor of the Burrard Building here at St. Paul's. It's open 9 to 4, 7 days per week. Walk-ins are welcome, and it's a first come, first served clinic. I like to tell people that just because it manages expectations when they come to the clinic. It's meant to stabilize patients in the short term with evidence-based addiction treatment, not just for opioids. And then they are connected with further clinics or reconnected if they are previously associated with a prior clinic. And as of data that was completed on June 1st, 2018, there's been over 2,000 patients seen, which I would imagine has grown exponentially since that date, with 930 started on opioid agonist therapy. And this clinic opened in 2016. The overdose outreach team is a team that is providing support to individuals who have recently experienced or at high risk of an overdose. They work out of the downtown east side, and they do present to the various hospitals and can be called in referral. Their goal is to connect with individuals who are not well connected elsewhere in the community. They provide overdose prevention education. They give information on OAT, and they help patients navigate to appropriate services. To be able to refer to the overdose outreach team, it's an automatic referral for overdoses here within St. Paul's Hospital, but they also provide referrals with consent for other substance use disorders. And it's important when you call them to give them the best way to contact the client, because many of the patients that may be accessed by or may be a candidate for the OOT may not have a phone or an address. So being able to provide the OT with a typical hangout as well is important. So to date, and I've been lucky enough to been given permission to share this data so far by Dr. Kessler and his team. There have been 22 kits dispensed since middle of December, 12 males and 10 females. And as of March 29th of 2019, we have follow-up data on 15 patients. Now, 4 patients are still on Suboxone, so that's 27%. So comparing this data to the D'Onofrio study, that's quite a lower number. Reasons for this may be that it's an incomplete data set. So we only have data on 15 out of 22. And this data is continually being added to. This is aggregate data, so it's not the 30-day post-Suboxone start or Suboxone dispensation. The patient population may be different and is different because the study by D'Onofrio was between 2009 to 2013. So based on that timing, you can hear that fentanyl had not yet been added to the drug supply, at least in Vancouver. And the patient population is likely very different than the northeastern United States here in Vancouver. So just some statistics based on the D'Onofrio study. Approximately 30% of these patients in the D'Onofrio study were educated had taken some college, and 2 to 8% of these patients had finished college. Approximately 50% of the patients in the D'Onofrio study had full-time employment, and 10% had stable living arrangements past the 30 days. So it may be different than the patient population that's being accessed here at St. Paul's Hospital. And I've been given permission to share this data by Dr. Jessica Moe, who is the lead on the Suboxone ED starts at Vancouver General Hospital. There is a plan for a rollout of ED Suboxone being provided from Vancouver General Hospital as of summer 2019. The plan is to first enroll groups of 10 and 10 patients for a standard dosing start and a microdosing start. So this will be a feasibility study looking at the feasibility of standard dosing versus Suboxone microdosing. And the plan is to follow up with these patients at 7 and 30 days post ED Suboxone dispensation. So as I mentioned, standard dosing will be provided, the standard dosing group, the patients will be provided 36 milligrams of Suboxone total to be taken over 3 days. The microdosing group will start at 0.5 milligrams BID, which is doubled daily until they're taking 12 milligrams on day 6, with the plan for cessation of opioids at that time. And ultimately, these patients should also be considered for a script with adjunctive medication should they either have withdrawal or discomfort from the withdrawal prior to starting Suboxone, or if they have precipitated withdrawal from their Suboxone start. So take-home points from my talk today. Imperative to offer take-home naloxone for patients who have disclosed substance use in the emergency department, and consider providing take-home naloxone and screening patients who present to the emergency department with complaints that may not be related to overdose. I would advocate for the counseling of patients regarding safer substance use, so harm reduction strategies, including location of overdose prevention sites, clean supplies, using test doses, and drug checking. And the take-home Suboxone starter packs being offered at St. Paul's and BGH shortly may engage individuals in treatment in a timely manner. Data is still forthcoming. So I'd like to thank the following people in the preparation of this talk: Dr. Keith Ahmed for provision of some of the slides and information, Ms. Emma Garrett for provision of the data, as well as Dr. Andrew Kessler for provision of data, Dr. Isabel Miles for support during the presentation of this talk, and Dr. Jessica Moe for information as well. Thank you very much.
Thank you. I'm sure Anne's happy to take some questions from the audience.
Thank you for the great talk. I understand that take-home pilot study.
Take-home Suboxone?
Oh, yeah.
Okay.
Right?
Sorry, yeah.
So is there's a disparity between, like we have Syria and Vancouver, two different homes for people present, say, in here or BGH, they get different treatment or different access than if you present them in general. So people who I don't understand the need to divide it. The two house authorities, that doesn't make any sense whatsoever, because there's really mobility between the two, and they are both have the same kind of issues with the overdose crisis. And I know it's not really answer answer, but how would you advise people when is there maybe an exclusion thing? If you don't have primary care, you won't get access to that because it's easy to refer to RAC or connection clinic, but there's no such thing as like, once you cross boundary road.
So the question is regarding geographical location of patients and how we provide good care and continuation of these ED Suboxone to-go packs. My understanding is that there is a rapid access addictions clinic available in Surrey. I can't speak to Burnaby, but each of these ED Suboxone start programs have been very much based in, I guess, planning for where they would go after. And so at least with the VGH process, we're very lucky to be geographically close to the Rapid Access Addiction Clinic here at St. Paul. That being said, I think they would still take patients who are in Surrey if they do not have connection to care.
Yeah, the catchment area is not the issue. The issue is we have maybe a requirement to have primary care as the main issue. Bring people to care post emergency department visit or admission even.
I believe all of the patients that who are provided with ED Suboxone here have been either offered the Rapid Access Addiction Clinic here or have been sent back to their primary provider, understanding that their primary provider is able to provide Suboxone. I don't think that they leave these patients without a follow-up plan.
Just make a comment. So the RAC, we see people from like all over the village. We'll see everybody sees people from Alberta. And I think the fact is that looking at people with primary care, even just outside substance use, is very difficult. So we want people to have low barriers of follow-up because they're so difficult to treat care. In terms of specifically disparity in terms of perhaps different programs, remember the Suboxone to go is more of a pilot project, right? So you don't want to disseminate something that you're not quite sure what the outcomes might be or how it might be disseminated in other regions. But the main thing is that the main difference is that they're just providing physical Suboxone. It's not something that you cannot do within your own emergency department. And to go back to that initial simplest thing, the Genopio paper, over even 50% or 60% have had home kits. And that's just a prescription. That's the difference between the two programs. It only takes a number needed to treat of 2 to 3 to 9. That's crazy. If you think about other studies, like all the doctors do, that's an insane number needed to treat. So it is coming, and I know that there are plans to even initiate more standardized protocols for ED induction Suboxone to standardize that care for patients, but it shouldn't be a barrier for you because really it just needs that prescription, right? And some education behind how to initiate.
Thank you.
Jen?
Hi, thank you for your time. My question is, if we dispense some medications in the emergency department, it doesn't always show up in permanent. So in the case of the Suboxone to-go kits, is there a way for it to show up on permanent?
So I believe that the St. Paul's group access their kits through Crosstown, is that correct? And then that comes up on the Pharmanet, and the plan for VGH is to have that same system as well. Because I agree with you, not having OAT show up on Pharmanet can be potentially dangerous for patients.
And I can comment that actually it's like automatic. They fax a thing over to us and then they upload it. Okay. So that's a big thing about that too. Oh, we're just looking for Andrew. Here. Oh, there. You should be over.
So Pharmanet. So yeah, so it's we're still ironing out some kinks, but in general it's dispensed. Notification goes to Crosstown uploads to Pharmanet. So it should be there, maybe not instantaneously, but probably within 24 hours of the patient receiving it.
And then my follow-up question to that is, is there a limit to the number of restarts that can happen for a patient? Like how many, is there a limit to the number of to-go Suboxone starts?
That's a good question. I would say I don't believe there is, based on my my understanding of the program. I think it's just important to clarify the pieces of whether or not they've received any other opioids or opioid agonist therapy in between the Suboxone starts. Andrew, is that correct?
Yeah, I mean, no, I mean, I think we would make every effort to have an addiction consult if the person has received, I don't know, 2 or 3 buprenorphine to go kits in a row, and so something is kind of not working in terms of the connection to care. So I think we would try to escalate the level of care if the patient is willing, or walk the patient up to rack during daytime hours. So we may try to.
Yeah, I think that's the really nice thing about St. Paul's here is that we have such a robust addiction service that we have the resources to be able to support patients and timely access to consults and care. So we're able to escalate care should the need arise.
That might be one of the reasons why the numbers so far are pretty low, only in the 20s in terms of how many are being given out. I think that's because certainly during daytime hours, many patients would come straight from Emerge up to the rack, and we would do the Suboxone inductions there or microdosing take home from there. So that's probably reducing the numbers that are given the to-go packs.
For the microdosing to-go packs, the consultation that they're having with the frontline worker, does that include a discussion of, like, let's say the patient is on methadone, does that include like a discussion about like how long they've been on methadone, how much they're on, and like would a take-home microdosing kit be appropriate for all patients?
So right now, one of the exclusion criteria, or at least the flagging of these patients for an addictions consult, is previous OAT or current OAT. So those would be patients that it would be imperative to flag to at least the CPAS service at BGH.
I just want to clarify too about the comment. Right now, the to-go packs are just for staggered induction, so not microdosing.
They're not.
St. Paul's is only giving out standard induction packs. Jen?
Oh, I'm just so curious about the BGH Emerge program with addictions care, because at St. Paul's we have the addiction assessment nurse for 7 days a week. Now we have such a large AMCT team that I can see how it would be, easily the next step to start take up Suboxone. But at BGH, I don't know how. Could you describe how large their CPAC team is and how easy or limited the access is, and also do they have specialized addictions nursing to support that, and or will there be specialty addictions training for the emergency nurses? How is this all going to roll out there?
So just for people listening online, the question is regarding the structure of addictions care at BGH. So I will speak to the fact that it's not nearly as robust as St. Paul's. We do not have any defined addictions nursing specifically at BGH, and the CPAS service currently, I believe, has 6 physicians on staff. Right now, they have 7-day-a-week call in the mornings, but they do not have 24-hour on-call physicians. So it is imperative to be able to train the emergency physicians at BGH for those off hours where addictions consults are not necessarily available, and to consider holding over those patients for a morning consult with CPAS. But the hope is that we can make addictions care more robust at BGH, but that's my dream.
CPAS used to have 2 full-time nurses, and they gradually got whittled away over the last couple of years, unfortunately.
I just have a question around the microdosing. Perhaps maybe everyone has a different approach, but generally we have a significant educational component with the patients prior to dispensing it, in particular to ensure success for the induction, especially the first couple of days. I'm just wondering what the feasibility of that would be within an emergency department such as BGH with your high volumes and kind of the lack of addiction support, and how that might be mediated with your feasibility.
So the question is regarding the feasibility of microinductions. I agree that it will take quite a bit more education. I think that the plan moving forward with these is to have very robust emerge education piece for these patients, for the emergency staff to be educated, At this time, I agree that it may be feasible to have those first couple of patients be a CPAS consult, but Dr. Mo may be able to speak more to that.
Yeah, so I'm Jessica. I'm working very closely with Anne on this project with you. It's a great presentation, Anne. And thanks to all of our colleagues here who've been so supportive in helping us to start something here in VGH. But just to speak to those last couple of questions, it's very true that VGH is not as well resourced or as set up as St. Paul's is as far as addictions care, and a gap that Anne and I are hoping to address. I think both the standard dosing protocol and the microdosing protocol will require a lot of education for our patients. And so what we're hoping to do is to really empower the staff that we currently have in our merge, particularly the pharmacists that we have in the ER, not quite 24/7, but through extended hours of the day, to provide a lot of counseling in hours in which CPAS isn't available for consultation. We're working very close with the CPAS service to be available to help us with counseling and education piece for our patients. But we're trying to kind of arrange this, anticipating that hopefully down the road we could be able to get something like an addiction care in our emergency room. In anticipation of that, well, we're not there right now using the resources we have to empower our frontline nurses, our pharmacy staff, and building relationships with CPAS to provide better care for our patients.
Yeah, just a comment. I believe that ICY is currently doing take-home dosing of, or not take-home dosing, but they're doing home inductions of microdosing, where they have their patients wear alarms and they attend to a pharmacy twice a day. I can't speak to the success of that program, but Dr. Azar is part of it, and he said that it's going well for the patient population that they serve.
Okay. No other questions? Well, thank you once again.